So, moving on and talking about the lactating woman. All women are going to lactate. The length of lactation is going to be dependent upon how long they choose to breastfeed. The initial period of lactation is when the colostrum is present, and colostrum can be expressed typically immediately after birth. Around 3, 4 days, that's when we see that colostrum changing over into mature milk. So when you're looking at colostrum, or if you see colostrum, typically it's a kind of a golden colored. And so when you're talking to breastfeeding educators and lactation support persons, they will kind of describe that as liquid gold because it has great immunologic support. However, you need to think about cultural diversity, and there are cultures that believe that the colostrum is dirty, such as the Native Americans, and so don't be forceful. They will, in turn, begin breastfeeding once they go home, but the colostrum is the first part of lactation that occurs, and then the mature milk will come in, and as that mature milk comes in, the woman will probably have her breasts will be warm, firm, oftentimes tender, and maybe feeling warm, especially from like the chest up. With non-lactating women, that engorgement continues to occur around 3 to 4 days. Her breasts will be very painful, very sore. It's best that she not express milk, express colostrum, pump, only none of those types of things, because it will make that engorgement even worse, because lactation works on a supply and demand type mechanism. And so if she is producing or expressing more milk, she will continue to make more milk, which will only obviously lead to worsening complaints. Engorgement will resolve spontaneously on its own. It typically takes about 24 to 36 hours, and then usually by the end of a week, it will be completely resolved. During this time, it is a good idea for her to wear a very tight, supportive bra. Utilize ice packs to help decrease inflammation. Sometimes mild analgesics will be good, so Tylenol, ibuprofen, using breast binders, anything of those types of things. So important that we do provide education as far as engorgement goes. As far as the mom's perfusion postpartum, we do know that her plasma volume increases by about 50% during pregnancy, and so it will take time for that to return to that normal pre-pregnant state. It does have estimated blood loss values listed out up here, and remember that is just an estimate. Typically 6 to 12 weeks postpartum is where we're going to see pulse rate, cardiac output, those types of things returning to normal. And with varicosities such as hemorrhoids or varicose veins, those things will resolve independently, and she may need to use such things like Tux pads or Nuvocanol cream, those kinds of things to help with pain. But otherwise, supportive TED hose, those kinds of things will be important for her. With her skin and muscles, the chlasma, which is, remember, that pregnancy mask that appears on the face, typically disappears by the end of pregnancy. And unfortunately, hair growth does slow after delivery, and we may see a time of increased hair loss, and that's just due to hormonal changes. We did talk about early in the unit that she has increased flexibility. Her gait and posture tend to change over time, and all of that should return around 6 to 8 weeks postpartum. It's a good idea to tell her not to buy shoes during pregnancy, because oftentimes women do say that they have an increase in shoe size. Maybe not the entire size of the shoe, but their feet do tend to increase in size during pregnancy. When you're thinking about your normal postpartum nursing assessment and routine nursing cares, buffles is something that you should always remember. So with buffles, these are the things when you're doing your focused assessment you have to look at. So breast, uterus, fundus, the firmness, lochia, episiotomy, stitches, and then also consider her pain and emotions. So when we are doing our assessment, focus assessment, that should be key to every single assessment that you do on an OB patient. Episiotomy care, things that we can use: dermoplast, the peri-wash bottles, sitz bath, ice. All of those things are going to be very good to help decrease swelling, decrease pain. With our C-section, again, add that postpartum C-section assessment that we talked about in the last chapter, using the Rita and assessing her incision for that, watching that surgical dressing in that immediate postoperative period, and then listening to bowel sounds to ensure that her bowel sounds are returning early in the postoperative phase. So thinking about teaching plans, you do need to take a moment and read the criteria for early discharge. So if you do have a woman that wants to go home in those first 24 hours after delivery, the greatest risks are going to be those women that have poor feeding. They're at great risk for infection, that maybe the baby is already showing signs of jaundice. So do take a look and read that information about criteria that has to be met for early discharge. Teaching plans, these are just nursing diagnosis that you can take a look at. And then think about each intervention that will follow these. Promoting bonding, early skin-to-skin contact is very important for bonding. It's also an excellent way to provide thermal regulation in those early periods. It also helps attachment. It helps with breastfeeding. So there's lots of great benefits out there to early skin-to-skin contact. We do encourage families to room in with their infants, and so just increasing bonding. Watch communication between parents. Watch the touching, the eye contact, voice, those very different, all those different things that are going to be going on when the infant is delivered, and we start that whole bonding process. This will be part of your women's health paperwork too, that you do need to be cognizant of. So I would take a moment and read about ways to promote early infant bonding and encourage of that bonding. When we talk about breast and formula feeding, again, this is going to be referred into chapter 26. We feel that is important in the postpartum period because we definitely need to consider breastfeeding and the importance of breastfeeding, especially during the first 6 months of life, and then continuing in that on for at least the first 12 months of life. So exclusively for the first 6 months, and then at least for the first year of life. Typically, when you think about the female's breast, each breast is composed of about 15 to 20 segments or lobes, and each lobe has as many alveoli. So I'm not talking alveoli that are located in the lungs, but they look like alveoli, and those are milk-producing cells. So there's anywhere from 15 to 19 pores that breast milk is transferred to the suckling infant when the infant starts breastfeeding. And so typically we should see the breastfed infant eating about every 2 to 3 hours. And when we're talking about 2 to 3 hours, it's from start of breastfeeding to start of the next breastfeeding. So maybe it takes you an hour to breastfeed that baby, and then maybe in an hour again the baby's going to be ready to eat, and that is very normal. Breast milk is made exclusively for our infants' digestive systems, and so breastfeeding is the number one way to feed your infant because human breast milk is made so exclusively for the infant's needs. Bottle-fed infants are going to space feedings out a little bit because there's extras in the formula. So every 3 to 4 hours is going to be very typical. And then again, both of these statements say on demand. So if the baby is more hungry, we feed them sooner. And if it's a little longer, that's okay too. Infants do tend to do some cluster feedings. And so with cluster feedings, what we see is maybe they breastfeed every 2 to 2.5 hours throughout the day. And then there might be a period of time at night where they go 5 hours. Same thing with the bottle-fed infants as well. So when we continue to think about benefits and contraindications for breastfeeding, with breastfeeding, benefits are listed out up here. I can't really begin to tell you all the important benefits of breastfeeding listed out up here. What I want to address are the contraindications, because I think that everyone hears about the benefits of breastfeeding as far as decreased risks for mom, decreased risks for babies, benefits, those types of things. Contraindications: if mom is on cancer therapy, so receiving radiation, receiving chemotherapy, active TB or HIV. Obviously, if we move and think about underdeveloped countries where with women that have tuberculosis and have active HIV cases, that might be the only way that those babies get fed. So obviously, we're not going to not allow those women to breastfeed. But if you are in the Western world and women have access to formula and those such things, we do kind of want to steer her clear of breastfeeding with active TB or HIV. If she would have herpes simplex on the breast tissue, galactosemia of the infant, which is just the infant's intolerance to maternal lactose, cytomegalovirus if mom has substance abuse, because remember, whatever mom is putting in her body, that it does get transferred to breast milk in small amounts, but nonetheless it still is getting transferred into the breast milk. Additional things to think about for benefits with mom: she does need to have an additional 200 to 500 calories a day extra. We need to ensure that she has adequate fluid intake, and by adequate fluid, I'm telling you at least 10 8-ounce glasses of non-caffeinated beverages every day. It will help with weight loss. It's easy as far as it's always there. It's convenient. It's a great way to promote bonding. It is not effective birth control. However, menses may be delayed for a prolonged period of time. So when we think about the assessment of breastfeeding, this should be done in your women's health clinical. If you have not already done so, you will be doing this. So when we're assessing, these are things that we need to be looking at. So positioning, latch, let down reflex, frequency of those feedings. So when we're thinking about positioning, the biggest thing that you need to remember, there's 4 positions, and mom can choose what is most comfortable for her. So there's the cradle, the cross cradle, side lying, and the football hold. But with positioning, we want to ensure that as much of the areola is in that infant's mouth as the infant will allow in. We also want to ensure that when the infant is feeding, that the nose and the chin of the infant are in contact with mom's breast tissue, and that just helps prevent pulling and tugging, specifically on mom's breast, specifically the nipple. Looking at the latch, making sure that that areola is deep inset into the baby's mouth, that the tongue is down. Let down reflex is sort of a tingling sensation that mom can feel when the breast milk is starting to be released. A lot of women say that it feels kind of like pins and needles at the end of the breast. She should be able to feel a gentle tugging as the baby sucks. And what you should see with the baby is that the baby sucks with rounded cheeks, the jaw glides smoothly, and that there is an audible swallowing. So a lot of times when we listen for an audible swallowing, what we hear or what we see are several sucklings and then followed by several clicks, and that click is the baby suckling. We do want to ensure that mom doesn't have pain with latch. If she does have pain, then we need to take the baby off and try to gain adequate latch. Frequency every 2 to 3 hours in the first 24 to 48 hours of life. We don't want to overfeed babies, so duration, what we typically say is about 30 to 40 minutes or 15 to 20 minutes on each breast at each feeding. Don't set time frames and don't, watch the clock, those types of things. The woman will get into feeding habits, and the way to determine that the infant is feeding well is that at the beginning of the feeding, the breast should be relatively firm, and then it softens up as the milk is expressed. And we do want to ensure that each breast is that the baby latches and nurses on each breast with each feeding, because we want the baby to get that hind milk, which is there's foremilk and hind milk, and the hind milk is the milk that is higher in fat content, which means we're going to have good weight gains. Watching INOs, so dirty diapers, wet diapers, engorgement we've talked about, sore nipples. If mom has sore nipples, what we can encourage her to do is use some lanolin cream, some cabbage leaves, those types of things to help decrease pain, decrease swelling, maybe some ibuprofen over the counter. Plugged milk ducts will heal on their own. It's encouraged that we tell mom to massage her breast, use some heat and Tylenol until that plugged area is worked out. And with plugged ducts, the best thing to do is have that baby continue to nurse. And then mastitis is going to be a red streak and that is on the boob or the breast itself. The tissues turn red. And so those types of things are going to be followed with fever and pain. And then mom's going to be needing to see her physician for an antibiotic order.